So this quiz actually intend to show you that even if you have read, you can make mistakes. And that is the whole sole purpose of this class. That you have read a topic, still what are lacunas within your reading so that we can improve upon. And one more thing, that you have answered the previous quiz also in less than a minute for every question. This quiz also less than a minute for every question. And this is how we subconsciously train you for your exam. So in exam, the time should not be a factor. So yeah, this is one purpose of this quiz was most important that you should understand that the question can be framed on the same topic in a different aspect. Once you have that in your mind, it will become very easy for you to understand that okay, this is the topic which I'm familiar, but these are the catch. Once you keep a habit of it, and so we assume that you can grow and develop that MCQ mindset for SS preparation. That is the whole sole purpose. So let's discuss. Starts with shock. So what is shock exactly? Shock is a state of hypoperfusion that leads to inadequate cellular respiration. So what is cellular respiration? That cells are taking in glucose, utilizing it with the help of oxygen, converting it into carbon dioxide plus ATP. So these are the most important end products of cellular respiration, and these becomes the currency of cells. Now CO2 is energy currency of cell, and rather ATP is the energy currency of cell, and CO2 becomes waste currency of the cell. Now, this is one very new term for you. Yeah, there is something called as waste currency also. So both of them are important. What happens is because of hypoperfusion, what does that mean? Either glucose or oxygen is not reaching the cells, as a result of which the cellular respiration is impaired. So what will happen if there is inadequate volume that is reaching the cells? Most common cause of this is hypovolemia. So most common cause of hypoperfusion is hypovolemia, and that's why hypovolemic shock is the most common shock. And we know from physiology days what happens if there is hypovolemia. The heart will increase its heart rate. Why? To increase its cardiac output, because we know what is cardiac output is stroke volume into heart rate. So if heart rate increases, cardiac output increases so as to increase perfusion. When there is decreased perfusion going into kidney, what happens? Kidney releases renin-angiotensin aldosterone system. Aldosterone causes sodium and water reabsorption. Similarly, from the last class, you know, whenever there is any type of stress to the body, the neuroendocrine system sets in. It will release CRH. CRH will act on pituitary to release ACTH, will work on adrenal to release cortisol. And that is the load that is present on heart for it to pump against. Tension or the volume that goes to the heart is called as preload. That is the volume against which heart has to contract. मतलब हार्ट के ऊपर जो भी वाटर आया, आई मीन ब्लड आया, दैट बिकम्स प्रीलोड. इसके अगेंस्ट कॉन्ट्रैक्ट करना है टू पुट इट आउट, बट बाहर भी भेजने के लिए वहां एक वस्कुलर रेजिस्टेंस है. So heart has to cross that vascular resistance so as to push this blood into the blood vessels. The vascular resistance is afterload. What blood has come hence is preload. We'll use this concept in a while. So this is what you know, that adrenaline will cause vascular spasm and will increase afterload. Similarly, adrenaline will also act on respiratory system and increase the respiratory rate, both central as well as at peripheral level. So this is what you know. What is new? What exactly happens at cellular level? So now we know that there is hypoperfusion. So what happens in hypoperfusion? Either glucose or oxygen is not reaching the cell. What does they use to do? Tell me, what is the end product of glucose if oxygen is present? You know, carbon dioxide and ATP. What is the end product of glucose if oxygen is not present?
Lactic acid.
Very good. So glucose, if there is less oxygen, will produce lactic acid. But will it produce ATP?
Yes, sir.
Yes. How much?
Sir, two.
Very good. So ATP produced are only two, against if carbon oxygen was has been there, ATP produced would have been
32.
32.
32. Great. Even they can increase up to 38 if you take into account the NADPH that has produced.
NAD.
So 32 is the apt number. if it goes through the glycolysis, Krebs cycle, and electron transport chain. Very good. So ATP production has decreased. What has happened is there is lactic acid. So the lactic acid is being produced that comes out of the circulation. Acid is increasing. That will lead to what is called as acidosis. ATP production has reduced. So what requires ATP is the sodium potassium pump. The sodium potassium pump is needed to put the sodium out and pull the potassium back. This will not function. So the potassium will remain outside the cells and the level of potassium will start increasing. Thirdly, lysozymes present within the blood vessels also need the sodium potassium pump to function. If ATPs are low, these lysozymes start releasing their lytic activities within the cell, and these lysozymes will start disintegrating. This will lead to cell lysis. And what will cell lysis do? Whatever potassium is within the cell will also release it outside. There is acidosis, there is hypoxia. Both of them can activate, you remember from your last class, hypoxia and acidosis can activate complement system, and once complement is activated it will activate neutrophils that will release free radical oxygen and that will damage the endothelium. Damaged endothelium, less perfusion, less glucose and carbon dioxide, and hence the cycle will repeat. So what three factors that has produced at cellular level? One is anaerobic respiration leading to acidosis. One. Second, hyperkalemia. Third is activation of complement system leading to endothelial damage. So these are three basic things that happens at cellular level in cases where there is impaired perfusion. Do you guys get it?
Can you just repeat those three again, please?
Okay. So what first lactic acid is produced, so there is lactic acidosis. One, the potassium tends to increase outside the cell, so there becomes hyperkalemic state. And third is activation of complement system. All these three lead to a vicious cycle that happens within the cell that increases more or rather decreases more and more perfusion. So impaired perfusion is self-propagating, more impaired in perfusion. Now you guys hit it.
So that hyperkalemia is due to the
Okay.
sodium potassium pump
Yeah,
failure.
I'll tell it again. Now, what does sodium potassium pump do? It takes the sodium out and puts the potassium back into the cell. If it is not functioning, the sodium will stay within the cell and the potassium will stay out of the cell. So, potassium cell in extracellular space is increasing. Moreover, there is lysozyme that is disintegrating the cell. Whatever potassium is inside is also now released. Understood?
Yes, sir.
Okay, this is how it develops hyperkalemia. So, if you're still wondering, I'll let you remember your action potential thing. The sodium can gets in, leads to depolarization. This was the sodium potassium channel that throws the sodium out, lead to depolarization. Remember?
Yes, sir.
Great. So once you understand this basic fact, this was actually your first question. In a shock state, we know there is low perfusion. But what happens at cellular respiration level? Switch off anaerobic to anaerobic metabolism. That is true. Whenever first statement is true, wait, don't jump and mark it. This is purposely capped these questions in which the last option is all of them. So you have to wait, read all three, and then only answer. Next is hypoxia. Yes, there is hypoxia. Third is failure of sodium potassium channel. Yes, there is failure of sodium potassium channel. All of them are correct. Once you understand what is happening at the cellular level, let us discuss the types of shock. And this is the most important area because maximum questions are formulated from this particular part. And you guys need to understand it very clearly. Most common type of shock I have already told you is hypovolemic shock. What are the two types of hypovolemic shock? One is hemorrhagic, we all know. Second is non-hemorrhagic. So to understand it better, let me make a simplified diagram. And with this diagram, we'll continue in the rest of the class. So this is the venous side of the heart. It will go into the right atrium. From there will be right ventricle that will go into the lungs, forms the pulmonary circulation, comes to the right side of left side of the heart. From there will be aorta. So, what is hemorrhagic shock? That is okay. First of all, what is hypovolemia? That is decreased intravascular volume. Understand? So, how can there be decreased intravascular volume? There is leakage of blood either from the veins or from the arteries. There is breach in the wall and the blood is going flowing out. Hemorrhagic, most common type. We all remember. We all deal with it. Non-hemorrhagic shock. How does that happen? So I told you it is decrease in intravascular volume. How can there be a decrease in intravascular volume without losing blood? It means the decrease in intravascular volume is called as dehydration. You are losing water if you are not losing blood. How can you lose water? Either you are not taking in or losing it out. What are the three areas where you lose it out? Through mouth in form of vomiting, through stools in form of diarrhea, and through urine in form of increased urine output. What are the conditions in which there will be increased urine output? It could be diabetes, both like diabetes insipidus or D. You guys, if you remember your decay pathophysiology, there is more of acidosis, more of solute overload that leads to increased washout. Skin excessive sweat, yes, very rarely that will lead to shock state. If you are deserted or something like that, then only, yeah, excessive sweat loss will lead to shock state, more not because of losing water but because of losing salts. So this is one, but very rarely that happens. Next is one more area where you can lose the intravascular volume is actually not evaporating it but losing within the body. That is what we call you drown within your own self. Like there is increased capillary pressure. So any reason, and the fluid is seeping out from the blood vascular system into the tissue fluid. So that is called as third space loss. It can happen in any inflammatory state, may it be pancreatitis, may it be any systemic inflammatory state also. So in those particular conditions, and one more most important for surgeons is intestinal obstruction. In cases of intestinal obstruction, what happens is the gut becomes a reservoir for third space. So the fluids tends to seep into the blood, into the gut from the blood vessel system. As a result of which, there is decrease in intravascular volume. So non-hemorrhagic shock is also very important, and it is far more common in medical part of the world. Yeah, hemorrhagic shock is common for surgeons. That is true, but non-hemorrhagic is also important, and we need to remember that. Once you understand it, you will be easily solve the next question. Now, next question is framed very practically. There is a 60-year-old male, uncontrolled diabetes. He had a bout of alcohol last night, roaming on the street, had blunt trauma to neck. He is vomiting, so he has vomited soiled clothes, and now he reaches in hypovolemic shock. Can diabetes be a reason? Yes, he's uncontrolled diabetes. He can have DKA. Can vomiting? Bout of alcohol? Of course, vomiting can be there, and is actually vomiting also. So yes, it can be reason for hypovolemic shock. Single bout of alcohol in a uncontrolled diabetes is a risk factor for pancreatitis, and pancreatitis can develop within a day. So yes, pancreatitis, third space loss can also lead to hypovolemia. But can blunt trauma to neck lead to hypovolemia? Very rarely. It is almost practically not possible. If there is a blunt trauma to neck, what we think of is there are major vessels and there can be trauma to them and lead to rupture of these vessels. But understand, if the skin is intact, if there is blunt trauma, if there would have been a sharp trauma or incised wound, that is a different story. It is a blunt trauma, so it is contained within the neck vessels. And you remember there is a deep investing layer of the cervical fascia which is very tough. So there is a tamponade effect on the blood vessels there and there itself. So the option was purposely kept so that you understand the concept of non-hemorrhagic hypovolemia. You guys understood it. Next, most important difference and what we need to understand is obstructive versus cardiogenic shock. So let us discuss about obstructive and cardiogenic shock. The diagram remains the same. So what is cardiogenic? Let's start with this. So in cardiogenic shock, what happens is there is intrinsic damage to the heart muscle, as a result of which the heart is unable to generate enough cardiac output. So the cardiac output is low because there is damage to the heart muscles. And since the job of left side of heart is to generate the cardiac output, it is invariably because of damage to the left side of the heart. And what are the conditions that can lead to this? Myocardial infarction, most common, dysarrhythmias, valvular heart disease, in that particularly aortic stenosis. After that, there could be myocarditis, DCMP. That's it. So all these causes, there is damage to the heart muscles. As a result of which, there is not enough cardiac output that is generated, and hence it leads to decreased perfusion. So it is intrinsic damage to heart. And for practical purposes, we will remember it left side heart. So what will happen? The blood will start accumulating within the pulmonary system, and there will be pulmonary edema or venous hypertension. That is most important feature of cardiogenic shock. But on the other hand, what happens in obstructive shock? There is obstruction to the flow of blood into the heart. So there is obstruction to the flow of blood into the heart system. As a result of which, what happens is heart is not able to get enough blood to put it out. Remember what I told? Heart is not able to get enough blood, means there is decreased preload, and it can be because of anything that causes obstruction to the flow of heart. Maybe IVC obstruction, maybe SVC obstruction, even if there is something within the heart like cardiac tamponade, or there is a positive pressure within the body cavity like tension pneumothorax, massive pulmonary embolism that doesn't lead enough blood reach on the left side of the heart. The left side of heart is fine, but it is not able to generate enough cardiac output to make perfusion. So cardiac output is low in both conditions, but the reason is different. One reason is that the heart is intrinsically damaged in one. The other reason, the heart is not getting enough blood to pump it out. This is the basic difference between obstructive shock versus cardiogenic shock. Now you automatically remember cardiogenic shock is a disease of left side of heart. Obstructive shock is a disease of right side of heart. So subconsciously we have made it in that sense that you understand it better. Secondly, pulmonary edema and venous hypertension will be features of cardiogenic shock. However, venous engorgement, neck veins distension will be a feature of obstructive shock. Neck vein distension, feature of obstructive shock. Now you guys understand it. This is very important. If you have any doubt, let me know.
That way, both of them are interrelated also, right? One, this will
Uh,
cause that way, right? Like,
they actually are independent entities. They are not interrelated. There is a
And
separate line between the two.
only if
Now,
the
for
left sided
example,
heart failure is too profound, it will lead to right sided failure because of cord
that is
permanency.
if that before that
Right, that is a very late stages,
you'll
yes,
die
sir.
of shock. Failure is different. Shock is different. Heart failure is something that is preceding card shock. Yeah. So heart failure will happen is that what is heart failure is not able to generate enough cardiac output. But what is shock is now it is not leading to cellular respiration. So what has happened is cellular respiration is also impaired. Once that has set in, yeah, having left-sided disease going into right is not important at that particular point of time. If you're asking me, sir, can we have neck vein distension in cardiogenic shock? If a person has a cardiogenic shock, to develop a neck vein distension, he's already dead. Right? So if I give you an example, in cases of massive MI, when the person directly lands up into cardiogenic shock, what features you see with shock is acidosis. The pH drops to 6.97 that used to happen. Massive inferior wall MI. Did you ever see for neck veins? Yeah, exactly. That happen. So they are distinct entities. But if you are thinking pathophysiologically, yes, it left side of heart will invariably lead to right side failure. That is altogether different thing. But you need to understand what pathologies separate them. Why? Because treatment is different. In cases of cardiogenic heart shock, you need to supplement heart more. So you need to start on inotropes faster. In cases of obstructive shock, you need not to give volume, but you need to find out the cause and remove it. Like cardiac tamponade, you put in any inotrope, you put in any vascular volume, nothing will help. You have to drain. In case of tension pneumothorax, you have to drain the tension pneumothorax to treat it. So obstructive shock treatment basically lies on the management what has caused obstructive shock. For cardiogenic shock, you can't do much. It is actually the insult has already happened, and most of the times we only support of vasopressors or inotrope. Do you understand this factor?
yes, sir.
Great. So once you understand this, then let us come to this. What is distributive shock? So what is distributive shock? In this, heart is pumping fine. But what has happened is because of some reason, the systemic vascular resistance has decreased. What will it lead to? It will lead to increase in the volume of the blood vessels. We call it capacitance. So the capacitance has increased. मतलब capacity बढ़ गई. Capacitance. A simpler language, capacitance is the ability to accommodate people within, or if you say for vessels, accommodate volume within. For any reason, if the capacitance of vessels increase, if the amount of volume or the volume of blood remains the same, the pressure will decrease. So resistance has decreased, pressure has decreased. Pressure decreased, impaired perfusion, impaired cellular respiration. Or other reason could be the blood is not going through the capillary channel but has started shunting Because of shunt, this becomes the dead space. So the volume which was already present in the natural space has now gone to dead space. So the total amount of volume in which the blood was distributed has increased. As a result of which, again, the same thing happens. The systemic vascular resistance decreases and the pressure decreases. Now, remember from a while ago, I told you the vascular resistance is something which is needed for heart to pump. Is the resistance against which the heart has to throw the blood out. If that has decreased, heart can easily pump the blood out. So the cardiac output has increased. But despite increased in cardiac output, there is impaired cellular perfusion. This is what is distributive shock. Despite increase in cardiac output, there is impaired cellular perfusion because of decreased systemic vascular resistance. What I told you about systemic vascular resistance, what is we call it? Afterload. So the afterload has decreased. Now comes the most important thing. So afterload is decreased in distributive shock and preload is decreased in obstructive shock. Preload is the volume while afterload is the pressure. Yes, preload is the volume against. Now, actually, don't name it pressure and volume only because the pressure is directly related to volume also. So understand the fact. Yeah. So understand the fact is preload is the amount of volume the heart is receiving so that it can throw out, and afterload is the pressure or the resistance against which heart has to pump out. So once it has decreased, the afterload has decreased, what has happened is heart is now pumping more. So heart has become vigorous, but still it is not able to meet the demand. What is the reason? There is dilatation of the blood vessels. What is the most common cause of dilatation of blood vessel? Okay, what causes constriction of blood vessel is adrenaline. So, and what causes dilatation is histamine, acetylcholine, and all. In cases of anaphylaxis, what has happened is severe histaminic release. If there is severe histaminic release, there is increase in vascular resistance. The vascular resistance is decreasing, as a result of which what happens is there is the increased cardiac output but impaired cellular perfusion. As a result, there is distributive shock. The second reason is sepsis. Now you remember from the last class, in sepsis there will be release of dams that will act upon toll-like receptors, will lead to increased nitric oxide production, will lead to the same thing. Second thing, what happens in sepsis is what is called as AV shunting. The channels of AV where AV shunting is naturally present are usually closed. But in presence of sepsis, what has happened is because of damage to the normal endothelium or normal capillary vasculature, the body tries to make other pathways. So it opens up the AV system. What is the mediator? That is nitric oxide. Third and most, so both of them will lead to distributive shock. Third and most important, I told you histamine बढ़ जाएगा तो distributive हो जाएगा. Adrenaline कम हो जाए तो adrenaline can go down in what is called as neurogenic shock. What does that mean is shock because of damage to thoracolumbar outflow. So what is the sympathetic outflow? Is the thoracolumbar. Any damage of spine above this level can lead to impaired thoracolumbar outflow. What will this lead to? One very interesting thing. So there is no adrenaline, blood vessels are dilated. But now, if you remember, adrenaline is also needed for heart to contract. If adrenaline is not there, the heart rate will go down, the cardiac output will also go down. So, neurogenic shock is a worse condition in which there is low afterload, but the heart is not able to generate enough cardiac output also. Even there is bradycardia, the heart rate is also decreased. If you have understood this, then you can easily answer all these questions. Not all this, actually, this one is left. We'll discuss endocrine shock and then come to all these questions. So, do you guys understood till now? Okay, great. So, you understood the differences between obstructive shock, cardiogenic shock, and distributive shock. Now, let us come to one more variety, what is called as endocrine shock. Actually, it is not a variety of shock, rather, it is a mixture of all these shocks. Most common cause of endocrine shock is hypothyroidism or hyperthyroidism. So what happens in hypothyroidism is sensitivity to sympathetic system is decreased. Why? Because there is receptor down regulation. So if the sensitivity to all T3, T4 has decreased, doesn't it look like neurogenic shock? In neurogenic shock, there was no adrenaline released. Here, adrenaline is released, but it is not functioning. So, hypothyroid shock is equivalent to neurogenic shock in features. If we look to for hyperthyroidism, what has happened is cellular demand has increased. So, your basic metabolic rate has increased. So, cellular demand has increased. Even is increased to that extent that increasing cardiac output could not match with the cellular respiration, as a result of which we have what is called as high output failure leading to shock. It is that's why called as hyperdynamic shock. Right. Other part is adrenal. So in adrenal insufficiency, what happens is I've told you that aldosterone is released at the time of shock and it conserves water and sodium. If there is no aldosterone, what will it lead to? Hypovolemia, because sodium and water is being released into the urine. So adrenal insufficiency is equivalent to hypovolemic shock. Hypothyroidism is neurogenic shock, means distributive shock. And hyperthyroidism per se is a different type of shock that is called as hyperdynamic shock. Once you have understood it, now you can easily answer all of them. Now, shock with bradycardia. Don't look at options. Tell me the answer. Shock with bradycardia. There's only one shock, there will be bradycardia. Unmute and tell. You know the answer now. Shock in a patient with hypothyroidism is hypothyroidism, shock.
Neurogenic again.
Neurogenic again. What differentiates cardiogenic shock from obstructive shock? Cardiogenic is intrinsic defect. Yes.
The left side and obstructive
Left
is
side.
for the right
It's left
side.
side and right side. Good. So in look, let's look at this question. Cardiogenic is intrinsic defect. Yes. Cardiogenic and obstructive is extrinsic compression. Yes. Cardiogenic has increased preload, whereas obstructive has reduced preload. Okay. Yes, it is there. Cardiogenic has pulmonary edema, whereas obstructive does not have it often. Yes, it is also true. All are correct. Next is there is hypotension in a patient with warm extremities. So what is this question asking? Is asking there is
Distributive shock.
shock with warm extremities. Answer me one. In one word, which is this shock?
Distributive because the
Exactly.
vasodilatation.
Very good. Because in distributive shock, there is vasodilatation, so extremities remains warm, or there is AV shunting that also leads to warm extremities. One answer is distributive. Three forms of distributive shock is septic shock, anaphylaxis, spinal cord injury. That is it. All four of them. So this is one most important area for you guys to remember, because this is what will come in your day-to-day practice, as well as this is the area from which maximum questions in exam is formed. Once you have understood it, let's revise it again, and then we'll understand what happens to all these factors in different types of shocks. So you know now hypovolemic shock. The vascular volume is reduced. Heart is functioning good, so cardiac output will be high. Systemic vascular resistance means since there is loss of blood, there will be multiple factors that will come in and try to increase the arterial pressure. So systemic vascular resistance will be high. Even the venous pressure will rise. But what about mixed venous oxygen saturation? Okay, we'll talk about mixed venous oxygen saturation in a while. What is it? And we'll let you know. So, what is mixed venous oxygen saturation? So, you know what is oxygen saturation? So, this is the right side of the heart. So, you currently you know that if you take oxygen saturation, you need what is called as arterial blood gas. But if you know that all your shock patients will have a central line. Now, if they have a central line and we take blood from this and do an analysis in ABG, this is called as venous blood gas. The saturation of blood in this sample is called as mixed venous oxygen saturation. Now, I tell you one simple fact. The oxygen saturation in the arterial blood has to be 100%. In the venous side, it is 50 to 70%. It means that the cellular extraction is close to 30 to 50%. Are you guys with me on this? Okay. Now, if I tell you that in cases of shock, the cells are deprived of oxygen, so they will try to extract as maximum oxygen as they can. In cases of hypovolemia, the amount of blood that will reach to them, they will try to extract as maximum as possible, so the extraction rises and mixed venous oxygen saturation will fall. So in hypovolemic shock, it will be less than 50%. But what happens in septic shock? In septic shock, there is AV shunting, so the blood is not reaching the capillaries. If it is not reaching the capillaries, the oxygen won't be extracted. So in this particular state, what is happening is extraction is low, so the mixed venous oxygen saturation rises and it is more than 80%. Do you guys understand this? And ask me, what did you know?
How is the oxygen saturation will be high?
Okay, I'll tell you. Okay, understand you have 100 rupees and you are taking this to the market. You will spend something and come back. Usually you spend 30 to 50 rupees and you are left with 50 to 70. This day you are going to market, but you didn't went into the market and take a bypass route. So will you spend anything out of 100?
No.
So the amount of money left in you will be close to 100 if you have spent any. It won't be more than 100, but yeah, it will be more than at least 70 at least.
Yeah.
So it is more than 80% in cases of septic shock. What you took is the pathway of AV shunting rather than capillaries.
Okay.
Got it? So if you have got that, let us make it one step forward. Understand that there is a patient of septic shock. So you expect mixed venous oxygen saturation to be close to 80-90%. Now is what happening is his shock is still there, but the MVO2 start reducing. It means that whatever blood is going to the capillaries, they are extracting close to 50 to 90% of it. It means that the septic shock is getting converted into hypovolemic as well. So if in a patient of septic shock, mixed venous oxygen saturation start returning to normal, it doesn't mean that the shock is improving. It means there is an added component of a shock to this as well. So septic shock is now mixed with hypovolemic shock. Vice versa can also happen. Do you guys get it? Good. All of you understood it or not? If you want, I'll repeat it because it is very important.
So where does that AV shunting come from?
Why does AV shunting come from? Let us come back. So AV shunting in sepsis is because of nitric oxide release. What happens actually is in septic shock, you remember in septic shock there was endothelial damage. So normal capillaries are damaged, so blood is now forced to take alternate pathway and these channels are open. How are they open? Because of formation of nitric oxide. What it is? So once you have understood this, let us come back to this diagram. So in hypovolemic shock, the mixed venous oxygen saturation will be low. Let's come to cardiogenic shock. The cardiac output is low, systemic vascular resistance will be high because the blood because of the response. Since cardiac output is low, adrenaline will be released and will cause contraction in the systemic vessels. Venous pressure, we know there is venous hypertension, so venous pressure is also high. Mixed venous oxygen saturation, since there is no AV shunting, the mixed venous oxygen saturation will be low. This was obstructive shock, sorry, cardiogenic. In obstructive shock also, the cardiac output is low, the systemic vascular resistance is high, the venous pressure is high, and mixed venous oxygen saturation is low. So cardiogenic looks like obstructive only. The difference is in pathologies, what caused them. Next comes to distributive shock. The cardiac output is high, the only shock in which cardiac output is high. Systemic vascular resistance is low, the venous pressure is also low, and mixed venous oxygen saturation is high. If you understand this, you will now easily understand this chart of the Bailey. Forget about base deficit, we'll talk in a while. Let us read the rest. So what you told me? Which shock has high cardiac output? Cardiac output high in distributive, rest are low. Which shock has low systemic vascular resistance?
Distributive.
Distributive. It is there on your screen. So now you can understand how this chart is formed. So breast, it will be high, it is low there. In venous pressure is low in hypovolemic and low in distributive. Why? Because there is no blood only in the system to cause the venous pressure. Okay, veins don't contract. Veins don't have enough musculature to contract and build pressure because of contraction of their musculature. Okay. So mixed venous oxygen saturation is high for distributive, rest it will be low. Base deficit will be high for everyone. Why? Because shock at cellular level, what is happening is acidosis. Lactic acidosis will lead to base deficit only. What is base deficit? Okay, let me tell you what is base deficit is. You have, for example, say you have a pH, the normal range is 7.35 to 7.45. If acid comes in, the pH will drop 7 point, say, assume 1. So what will you need to reach it back, make it reach back to the normal? You need some base. This is the amount of base you need to make it back to the normal is what is base deficit. It is directly proportional to the amount of lactic acidosis that is present. Now, base deficit is not always related to lactic acidosis. It can be related to any acidosis. But yeah, base deficit, more the acidosis, more the base deficit. So base deficit will be high in all shock because at cellular level, the shock is same. Guys understood it. This is very important table. Okay. Hi everyone. So things are settled now. So now you understand mixed venous oxygen saturation, what is incorrect? In hypovolemic, it is less than 50. In septic, it is more than 70. In normal, it is 50 to 70. A normal value in a patient and shock is suggestive of mixed. I'll tell you one simple fact here only. We will discuss ABGs in one separate class, but I'll give you one hint. This is when I used to teach ABG. This used to be the last question I will always ask. So if I ask you one thing, if there is a pH of 7.37, you guys deal with ABG, right? Let me know first because yeah, okay, great. So there is a patient with a pH of 3.7.37. Acidotic, alkalotic, normal. The pH is not
Normal.
normal. If I say the bicarb of this patient is 10 and PCO2 says 20, does this patient has normal ABG?
No.
What does he have? I tell you, he has a mixed pathology. Now, before you come up and say, sir, it is acidosis with compensation, no, it is mixed pathology. He has metabolic acidosis plus respiratory alkalosis. Compensation, the rule of compensation is it is never complete. It means कि अगर किसी का pH 7.2 हो गया है, compensate होके वो 7.25 हो जाएगा, 7.35 कभी नहीं होगा. 7.35 होने के लिए या तो तुम्हें और there has to be a opposite pathology that has set in. How, when does this happen? I tell you. Metabolic acidosis, most common cause, let us say shock. Respiratory alkalosis, most common cause, anxiety. So a patient of shock who is very anxious and breathing violently, what will happen is washes out all CO2 because of excessive stimulation, not because he's the it is H positive ions that is driving more respiration. No, he's anxious also and he's expiring it a lot. Second situation is reverse that happens in case of metabolic alkalosis, maybe because of hyperkalemia. Plus, a patient has COPD that lands up into respiratory acidosis. The pH can be normal, but the bicarb and PCO2 both are abnormal. We'll discuss this in a major thing when we discuss on ABGs. But just for you to make a correlation, a normal ABG can have mixed pathology if there is deranged PCO2 and bicarb. A patient with normal MVO2 can have mixed pathologies if he has clinically evident shock. If the shock has resolved, that is fine. If the shock is there, he has a mixed pathology. It is not good recovery. Understood this? With a pinch of salt, I understand. Because I've not explained the entire ABG currently. Okay. Just remember this fact. Yeah, abhi samajhna hai. If you have time, I'll tell you in 5 minutes. We can. Okay. Chalo. Just a bit of it. Nothing. I will not go into major details, but I'll talk about acidosis. Consider this pH 7.25. The bicarb is, say, for example, 18. Now PCO2 I say is 25. Let us see what he's having. Whenever you read ABG, you read pH. It is acidosis. Before that, you have to read oxygen. We'll discuss some other day, but yeah, basics. So pH is low. It is acidosis. You see bicarb, it is down, it means it is metabolic acidosis. Then you find out for this bicarb what should be expected PCO2 by a formula what is called as Winter's formula, that is 1.5 into bicarb plus minus 8. 1.5 into bicarb plus 8 plus minus 2. So this is the formula. Like for this formula, 1.5 into 18 will be 27 plus 8 plus minus 2, it is 35 plus minus 2. So the PCO2 should be in range of 33 to 37. If it is in this range, we say it compensated metabolic acidosis. If the PCO2 is low or high, we say it is uncompensated. So if it is low, we say there is respiratory alkalosis component also present and it becomes a mixed pathology. If it is high, say 40, we say respiratory acidosis component is also present and it again becomes a mixed pathology. Why mixed pathologies are important? Because you have to treat both pathologies. It is not just composition. Fine. So in this case, if say for example the acidosis because of decay, so you have to treat decay. And there is concurrent respiratory acidosis, you have to treat respiratory acidosis, which is most likely because of COPD, asthma, or any obstructive pathology. We will discuss what is type 1 and type 2 failures and lot more things. Kushagar, by the way, has also put a videos on reading interpretation on the Insta page as well. Understood the difference between compensation and mixed pathology? Great. This was out of the topic. Let's move forward. So, what is recognition of the? Okay, let us once now have understood that the patient is in shock. What magnitude of shock she is in? Let us discuss that. So, first, one patient comes into the shock. Rather, he's happy. Then he started having shock, which keeps worsening. So, in compensated phase, what will happen is the body has conserved so and so that there is cellular perfusion impairment, but no evident signs present. The only or maximum evident thing you will get is increased heart rate or increased respiratory rate. This is called as mild shock or compensated shock. Actually, the mild shock term has now come. It was previously called as compensated shock, and it was thought that it is no shock. But now this term has come, and we'll discuss in a while. This term has called as mild shock now. So, important point is there is impaired cellular perfusion. Rest everything is fine. The BP is fine. The consciousness level is fine. The urine output is fine. The only thing that is increased is heart rate and respiratory rate. What happens in moderate shock? The person will start feeling anxious. His heart rate rises, his respiratory rate rises, his BP start falling, his urine output start falling, and the lactic acids will increase. So impaired cellular perfusion, how you know? Lactic acid increase. Severe, he becomes drowsy. Heart rate is very high, respiratory rate very high, BP almost normal, not normal, very low or unrecordable even. Urine output is anuric, lactic acidosis is very high. Once you have understood it, you can easily decode this table. So mild shock was previously called as compensated shock. You have lactic acidosis, increased respiratory rate, increased pulse rate. Rest is normal. There could be mild anxiety, but yeah, we consider it in mild, but Sebastian doesn't consider it, and we follow Sebastian for this table. But we are included. So this is mild, or rather, change in Bailey. In compensated shock, mild anxiety is also fine. In moderate shock, the person will start become drowsy. Urine output is reduced, respiratory rate increased, pulse rate increased. Most important factor, the BP will fall only in moderate shock. BP will be normal in mild shock. Urine output will fall only in moderate shock. It will be normal in mild shock. In severe shock, it will become anuric and the person will be severely hypotensive. So once you've understood it, it becomes easy for you to answer this question then. A person has tachycardia, low BP, bit drowsy, and negative base deficit means he is in shock with hypotension. It is moderate shock. Why not severe, sir? It is bit drowsy. The BP is still 90 by 60. So if he would have been comatose, BP falling low to 60 or below systolic, yeah, he will be in severe shock then. Understood this question? Once you have understood it, I'll move forward. It was easier one, so I'll just rush forward. Now comes the most important factor and why mild shock is important. So, shock only magnitude is important? No. What is important rather than magnitude is the time duration for which the person remains in shock. And if so, mild shock becomes very important because mild shocks are clinically not very appreciable, but there is lactic acid that is happening. The potassium is rising, at least at cellular level. What happens with this shock? If you start resuscitating them aggressively, what happens is lactic acid and potassium will come back into the circulation. There was complement system also activated that has free radicals that will also come back to the system, and the first organ they'll damage is heart and can lead to myocardial infarction, arrhythmias, or asystoles, and can eventually cause death of the patient, or it is related to mortality. This is what is called as reperfusion injury. So in cases of mild shock, if it continues for more than 12 hours, these accumulate up to such a big level that they can cause this damage. So it is not just the magnitude of shock, but the duration of shock that is also very important. Now, if I ask you what caused this reperfusion injury, you might say, someone can also say that, sir, we reperfused faster. Reperfusion would have been slow. Should have been very slow. Is someone amongst you also thinking this? Yes, but I'll say no. What caused this shock is why did you kept mild shock for more than 12 hours? You should have resuscitated it even faster before even development of this cellular level lactic acid, potassium, and complements. So how can you prevent a reperfusion injury? Is to eliminate shock maximally. Once the shock has set in for more than 24 hours, then the story becomes different. If a patient of trauma has come to you, or if a patient of septic shock has come to you, resuscitate him faster. Within 6 hours, his body parameters should be out of shock. The disease might be there. The pathology will take time, but the shock state should have been reduced. Understood this very important line, that reperfusion injury has to be prevented by eliminating or developing shock. So this becomes very important for this question, that the person was in mild shock for more than 24 hours. Somebody now resuscitated him with large volume of fluid. Initially showed good response but died of myocardial infarction. What can be the cause? Yeah, most confusing option was fluid overload. But remember one thing, you guys know, fluid overload can lead to heart failure but not lead to infarction. Specifically mentioned, if this question would have been he had died for reasons unknown, so fluid overload could have been option, but specifically mentioned in this question is myocardial infarction, and that happens because of fluid. That does not happen because of fluid overload. That happens because of reperfusion injury, and that is why the potassium is important. We talked about complement. What do they do? We talked about acidosis. What can it do? But we didn't talk about potassium. Na? What was the purpose of saying that there is hyperkalemia? This hyperkalemia can go back into the circulation and lead to cardiac arrhythmias and can even cause myocardial infarction. By activating complements that lead to endothelial damage, endothelial damage will lead to formation of coagulation pathway. The descending artery will get coagulated and hence infarction. Understood? Yeah. Okay. And the most important line, now you understand. Reperfusion injury can currently be attenuated by reducing the duration and extent of tissue perfusion. This is very important. And take me, this is question for you. This concept is very much discussed amongst all the peers in conferences. Reperfusion injury is something which we all are trying to tackle on. So this is one potential area for MCQ to come in next few years. Understood? If you have understood, this is very important. You should, yeah. So once you are done with this, now let us come to one more important concept. Now assume we'll talk about a shock in a case of trauma, and the shock in case of trauma is mostly hemorrhagic. So what does that do? So now you guys know, what does shock do to the body? Potassium high, acid high, complement activation. What does trauma do to the body? Is the entire metabolic injury chapter you guys learned last in the last class. So the end result is somewhere similar. When these two are combined, they lead to something which is called as acute traumatic coagulopathy. Why? So, and what happens in it? It leads to what is called as fibrinolysis, that is low fibrin, and platelet dysfunction. How does that happen? This activated complements will lead to local activation of platelets and platelet. Okay, if you remember, there are delta granules in the platelet. So that happens because of release of granules from the platelet. If platelet are damaged at cellular level, in the systemic circulation, the platelets will have no granules, so they will not function well, and hence they will not lead to coagulation in systemic circulation. In the local level, they have already consumed. Same goes with fibrin. There is more and more fibrinolysis that happens. The reason for fibrinolysis is still controversial, and that's why they have termed this as acute traumatic coagulopathy, and the reason for it becomes idiopathic. It is idiotic to the student and pathetic to the teacher who is teaching. It becomes very difficult to explain why does it happen, but yeah, it happens. It is one finding that is happening. We take that into account that this is happening. On the top of it, you start resuscitating. How do you resuscitate? With fluids. If you resuscitate with fluids, it will lead to dilution of all other coagulation factor. That will lead to dilution coagulopathy. You give fluids at room temperature, they will lead to hypothermia. Hypothermia causes activation of coagulation proteases and hence will damage all other coagulation factors as well, and hence lead to coagulopathy. So there is a coagulopathy to begin with. With our fluid resuscitation, the coagulopathy become worse, and this is what is called as trauma induced coagulopathy. So there was trauma and we induced this coagulopathy. It is different from acute traumatic coagulopathy because acute traumatic coagulopathy will happen. There is, you cannot avoid it. But your resuscitation has caused trauma-induced coagulopathy. But importantly, not all resuscitation, but resuscitation with fluids and resuscitation that has led to hyponatremia or hypothermia. So is this resuscitation good? No. Okay, one more thing. If fibrinolysis is happening, can we stop this fibrinolysis? Can you name any agent that can stop fibrinolysis?
Tranexamic acid.
Very good. Tranexamic acid, TXA. What leads to fibrinolysis is plasmin. Plasmin get activates from plasminogen. You inhibit conversion of plasminogen into plasmin, and hence fibrin will not be lysed. So tranexamic acid is given all patients with trauma, whether they are in coagulopathy or whether they are bleeding or not. Whether it should be given all patients with trauma. Am I saying it correct? I'll repeat my sentence. Tranexamic acid can stop this fibrinolysis. So shouldn't all patients receive tranexamic acid irrespective whether they are bleeding or not? Yes or no? Didn't understood. Okay. Only to the bleeding patients. You want to wait till this happens, then only we'll start. Or rather, you should try preventing the bleeding from this level only. This was the question of Crash 2 trial. So Crash 2 trial came in with giving two group. One group started with Tranexa for all patients who are come to trauma. Other group in which Tranexa was given only to the patients who were bleeding. They found that Tranexa reduced mortality in patients who came with trauma. Almost 2 to 5% reduced mortality as compared to those who are bleeding. So currently, all patients that comes with history of trauma and has shock, you should give tranexamic acid. So the criteria to give tranexamic acid is not bleeding, it is actually hypotension. And when we teach you trauma, we'll tell you if the BP is less than 110, start tranexa. Understood that? This is very important factor. So two most
Yes.
important concept from this. Great. So two most important concept that came from this slide is ETC is not equivalent to TIC. TIC is induced by resuscitation. ATC will happen, always happen. ATC can be prevented with Tranexa, and hence tranexamic acid should be started in all patients who come with just trauma. No, trauma with shock. Why he's doing so? What he's trying to prevent is acute traumatic coagulopathy. Understood? This is very important, and this is one question that came in 2024, and I expect it will came in 2027 also. Um, do you guys get it? Yeah. Chalo, let's move forward. What happens in hemorrhage? Now, hemorrhage is a condition in which there is shock and there is ongoing bleeding. So, what is your priority? Treat shock or treat bleeding first? Yeah,
Bleeding.
of course. That is one thing that is the goes without saying. Control of bleeding is the foremost thing in case of hemorrhagic shock. How will you control the bleeding? Okay, there's something I flaunt about, and I'll ask this to you as well. What is the most efficient coagulation factor?
Sorry, can you repeat, sir?
Yeah. Which is the most efficient coagulation factor?
Factor 8.
Okay, Darshit and Swapnil, any input from you? Darshit is thinking. Swapnil, I'll tell you, surgeon is the most important coagulation factor. It is you who will control the bleeding faster than any other coagulation factor present on this earth. So, control of bleeding requires surgical expertise, and whenever needed, do a step to control it. This is one thing my teacher told me, and this is one thing that has been with me throughout my life. Now I have learned about it. Yes, if who is going to control the bleeding? It is me who is going to control the bleeding. The BP coagulation factor comes next. Second, currently in current era, it is not just the surgeon, but intervention radiologists are very important because they can angioembolize and control the bleeding. All ways of controlling bleeding, packing, plugging, taking sutures, are effective if you control bleeding. Now I'll tell you a story because you are three of them. There was one patient of mine, we did a cytoreductive surgery. So there was a part of tumor that was left over the iliac vessels. It was not coming out. But we took a frozen, and it shows it has been responded to chemotherapy, which was given prior to cytoreduction. Then we gave her HIPEC. HIPEC is chemotherapy within the peritoneal cavity. On day 3, she bled to an extent her HB dropped from 12 to 2. We took her to the OT, controlled the iliac vessels, repaired them. Meanwhile, she was resuscitated and she was discharged on day 12. So, if the bleeding has been controlled, then only you can think of resuscitation, and resuscitation do work well. Hemorrhagic shocks have best outcomes. Septic shock has worst. So you guys need to know that in cases of emergencies, that is why you guys have been asked to stay. Similar thing happened with Whipple. There has been GDA, a tie that has come out. There was bleeding. We went in during a long course of your surgical career. You tend to have these complications when you operate on some 100 Whipples every year. Things will happen. Like cytoreduction, we go to close to 80 to 90 every year. So this is how shock. The point to emphasize here was control of bleeding is very important. Even if the person has bled to a hemoglobin of 2, if you have controlled the bleeding and did a good resuscitation, which we'll talk in a while, the chances of having patient surviving is close to 90 to 95%. So first thing foremost was control of bleeding. Next is you have to, with control of bleeding, you have to start resuscitation along with. So resuscitation will not happen after, but will start with. But tell me one thing, if you want to control bleeding, we remember to control bleeding, you need coagulation factors. That is true. You need blood pressure also, but not very high, but actually low. And you don't need hypothermia set in. You don't need dilution coagulopathy to set in. It means you don't need trauma-induced coagulopathy to set in. So will you give more fluids or you will restrict fluids? Let me know.
Restrict.
Restrict, yes. So this is one paradoxical thing I'm saying. There is bleeding that is ongoing. I'm asking you to give less fluids and cause what is called as permissive hypotension. It is very important. Why? Because if you try to increase BP to 120/80, whatever vessels that have been clogged by themselves will start bleeding. So you actually have a BP in a range of 90 to 60 with a map close to 55 to 65 only. Don't attempt a map of 70 or a BP of 120/90. Right? So this is what is your aim. You have to have a BP less than 80/60, sorry, 90/60, and above 80/50. This is not strict guidelines. It depends upon person to person. Like an elderly person, don't go to 90/60. For him, 170 is fine. For a young patient, you can go to even 70 systolic. Second is you don't give fluids more, so you don't induce hypothermia, you don't induce dilutional coagulopathy, so you prevent trauma-induced coagulopathy, and that is why there is less bleeding. But this happens only till you have not controlled bleeding. Once the ongoing bleeding has been controlled, now the patient is not a candidate for permissive hypotension. Now, bleeding will not happen. You have already controlled it. Now you will start him on resuscitative fluids for shock. What I was discussing till now is the concept called as damage control resuscitation. So what we are doing is we are doing resuscitation not to cause damage but to control damage. Even we understood from the last slide that even our resuscitative procedures can cause damage. We now tend to resuscitate in a manner that to control damage, not to cause it. This is what is called as damage control resuscitation. Once the ongoing bleeding is stopped, then you can go ahead and do your normal resuscitation for shock that is needed. That is, don't allow permissive hypertension. You take it to the normal BP because you don't want shock to persist long. Like, third thing, what is the other component of damage control resuscitation is coagulation that needs to be, you don't need to impair coagulation, and you need to avoid hypotension. So this is the basis for this very diagram of your bleeding. See, if it is bleeding, till you have achieved hemostasis, you will do damage control resuscitation. What are the components? Is a damage control surgery. It means you will go in and control only bleeding, see nothing else. If there is a septic process, remove it fast and but control bleeding and come out. Everything else will be seen later. You allow permissive hypotension. Then you treat the coagulopathy with Trenexa, platelet, and fibrinogen. There was hyperfibrinolysis, there was platelet restriction, there was Trenexa. We gave it to prevent fibrinolysis. So even if the patient is bleeding, we also giving Trenexa. Even if it won't be bleeding, we will still give Trenexa. Balanced transfusion is something which is needed because we don't want dilutional coagulopathy. So third component was dilutional coagulopathy, and the fourth component was prevention of hypotension. But once the bleeding is stopped, you go for perfusion targeted resuscitation, not for damage control. but you go for perfusion targeted resuscitation. So then you go for, in that you have to achieve adequate preload and afterload. So you will use all your fluids, all your pressors, no pressors here. Or if even if you're using minimal pressors, thromboprophylaxis you will definitely take. This monitoring is almost same, but the only thing is abdominal compartment thing you have to check in this perfusion targeted it so as not to increase so much fluid that it lands up into abdominal compartment. So if you have understood this, now you can answer about about permissive hypotension. It does it reduces dilation coagulopathy? Yes. Less fluids, less dilution. Helps in coronary perfusion? Yes. Why? Okay. One more thing I need to tell you. Heart is a very strange organ. Why? Remember this line of mine. Entire body receives blood in systole of heart, except heart, which receives blood in diastole. Are you getting? I'll repeat this line again. Entire body receives heart in the systole of heart, except heart, which receives blood in the diastole. If you are keeping permissive hypotension, it means that you are not allowing enough afterload to the heart. So this hypotension, which somebody started with saying, "Na, ki it is the pressure." Yes, it is pressure also, but not just pressure. It is resistance. So if there is hypotension, heart can easily pump out the blood and relax better. Relax better, more perfusion. So it helps in coronary perfusion. It's useful in hypovolemic shock. No, it is useful only in hemorrhagic shock. And you know, hemorrhagic shock is not equivalent to hypovolemic shock. It is a part of hypovolemic shock. And you stop permissive hypotension after you have controlled hemorrhagic shock. And you are left only with shock because of hypovolemia, which could be because of any reason. All of them are correct. No, this is the one of the most trickiest question which I have asked. The question framing is important in this. Why? Because if I have given any fourth option, like if I have added into it, like, so this becomes permissive hypotension is MAP less than 80 but more than 60. Now this becomes more wrong answer. So this is one of the question that comes in INISS, this type of question where you have to pick right amongst the rightest. Have you guys understood now? That once you have understood it, let's come to what fluids you will give in perfusion targeted resuscitation, PTR I call it. Fluids, we will discuss actually entire day on fluids, and I tell you it takes almost 4 to 5 hours for me to complete fluids. So for shock resuscitation, we'll discuss the minimum amount of fluids that we need. So fluids are ringer, normal saline, ringer lactate, D5, DNS, isolites, not many. There are much more to the list, but most common ones amongst this. What you need? Most common type is hypovolemia. So you want fluids to stay within the circulation. And these are all called as crystalloids. They are colloids as well. So what you need is the amount of fluid you should give should stay within the circulation. The best fluid to stay within circulation are colloids. I'm not saying they're best for shock. The best fluids to stay within circulation are colloids because they're not going anywhere. But the problem is they have very high side effects. Dextran can cause coagulopathy, HES is also linked with coagulopathy, platelet dysfunction, even allergies, up to that extent that it can cause anaphylaxis. So giving a treatment which has high side effects is not advisable. What are crystalloids? They will stay in the circulation. Some of the part of it will go out as well, but they're virtually side effects if used effectively. As a result of which, the crystalloids are preferred in shock management than colloids. So you guys understood why colloids are not being used. It's not because they don't stay in the circulation, it's because of the side effects. And your anesthetic friends are still using colloids because they're using it in a controlled environment. They don't need to rush 4 liters of HES. We sometimes have to rush 4 liters of ringer lactate into a patient. So that is what. So in shock, the treatment protocols are different. In maintenance fluid setting, the things are different. So crystalloids are better. Which among them is better? Normal saline or RL? If you ask me personally, yes, RL. If you ask me according to books, it is RL. The only reason is the pH of RL, the sodium load. The sodium load is in NS is 154, in RL it is 110 to 114. The pH is 6.9, इसका pH is 6.2. So even your fluids are acidic and you have a acidotic environment there. So less acidic fluid will always be chosen. But in two condition, D5 is okay. First, let me tell you about D5. D5 में क्या है 5% ग्लूकोज मतलब for 100 ml there is 5 ग्राम ग्लूकोज एक बॉटल में 500 ml हुआ मतलब 5 5 जा 25 and 25 ग्राम ग्लूकोज जैसे सर्कुलेशन में डालोगे ग्लूकोज एक्सट्रैक्ट हो जाएगा बचा क्या फ्री वाटर. Now, this free water, like diabetes insipidus, what happens in diabetes insipidus? That ADA secretion is lost. As a result of which, body is losing water. Body water lose कर रहा है तो सोडियम vascular space में ही है उसकी concentration बढ़ गई है. उस condition में if you give RL or NS, you are adding to the solute load. In that particular situation, your fluid of choice becomes D5. Understand this concept? So once you've understood this, next question is fluids versus vasopressors.
One doubt, sir. Will be used in CKD patients.
Can RL be RL you're asking?
Yeah, RL, sir.
Yeah. Okay. So CKD is a very dynamic understanding. So problems with CKD, let us see that and then we'll see whether we can give RL or not. What is happening in CKD? The kidney is not functioning. What was the general function of kidney? सोडियम बाहर भेजो, पोटेशियम बाहर भेजो, फॉस्फेट बाहर भेजो, सब कुछ बाहर भेजो. नहीं काम कर रहा है, सोडियम बढ़ गया, potassium but is potassium. So yes, RL can be chosen if the next fluid you will choose is NS. The better fluid in this particular condition is isolate P. The problem is not available in India. So what are we left with is NSRL ka choice. So C potassium. If potassium is normal, give RL. If potassium is not normal, give normal saline. Safer fluid, give normal saline. Why? Because you can take care of the contract the arterial part or arterioles per se and increases vascular resistance. मतलब वॉल्यूम कम हो गया है तो घर छोटा कर दो ताकि प्रेशर बना रहे. बेसिकली ये फंडा. बट अगर वॉल्यूम कम है और हम घर छोटा करेंगे तो परफ्यूजन भी तो और इम्पेयर हो जाएगा. इसीलिए whenever there is shock, first fluid then vasopressor. And Bailey 25 या 26 में लाइन हुआ करती थी never whip a tired horse. First give him something to eat and then whip him. These are whips. ठीक है किसी no. Start with fluids balanced, preferably crystalloids, and then start vasopressors early. This is the, in a nutshell, best resuscitative formula for shock. समझे? Once you have understood it, let us come to this. First line, therapy for shock in diabetes insipidus. Vasopressors, no. Inotropes, no. Same thing. Okay, what are the difference between vasopressors and inotropes? Vasopressors are those which will only act on arterioles. Inotropes are those which will increase contractility of heart. If you ask me, vasopressors can be given for any shock, but I will prefer them in distributive shock. If you want one answer, vasopressor is for distributive shock. Inotrope is for cardiogenic shock. You can use them, both of them in obstructive shock, but obstructive shock में कुछ भी use no for vasopress, no for inotrope. Crystalloids, yes, but diabetes insipidus में पूछा है. So not all crystalloids. Hypotonic solution, yes, very right answer. So you have to choose the right amongst the right, or rather rightest amongst the right. ठीक है? So this answer हो जाएगा hypotonic solution, and this is what is given in your Bailey. Okay, hypotonic solution like dextrose or poor volume expanders not used in shock unless there is free water loss, diabetes insipidus or sodium overload, that is cirrhosis. Understood? Once you have understood it, let's come to how will you monitor a patient of shock. What is the minimum requirement for monitoring a patient of shock? So what is the minimum requirement? Is do you need to require or monitor heart rate? Actually no. Why? Because heart rate will rise in any form of shock, starting from mild to severe. What you need to require to check is BP. Next is lactate. Next is SpO2, and then is ECG. This is the four minimum requirement that is needed for monitoring a patient in shock. Rest everything is additional. So since lactic acid takes time to understand perfusion, the marker to this is urine output. So minimum requirement is ECG, pulse ox, BP, and urine output. Lactic acid is additional modality. Okay? Even central venous pressure is additional modality. Invasive BP, cardiac output monitoring, it is all invasive. So all invasive modalities are not minimum. What clinically you can observe is minimum requirement. Monitoring for shock requirement is ECG, yes, pulse ox, yes, BP, yes, CVP, no. Once you up तुमने शॉक समझ लिया. You have understood what the shock, how does the shock evolve, what magnitude of shock, what is the duration of shock, what therapy you will give in for shock. But tell me, when will you end giving therapy? So what are the endpoints of recess? And also, what are the measures key? So the best way to assess. So if we have to maintain a perfusion, the best thing to understand whether perfusion is better or not is urine output. Easiest, simplest method to assess perfusion. If you want to assess is giving fluids helping patient or not, how will you manage that? Check for venous pressures. If giving fluids is helping patient or not, you have to check central venous pressure. uh, it lies from 5 to 15. बहुत सारे differences हैं. Less than 5 is something which people consider as low. If you give fluids, it rise and stays from 5 to 15. They are called as responders. If it rise for 2 to 5 centimeter of water and fall after 10 to 15 minutes, they're called transient responders. And if they don't rise, they're called non-responders. Non-responders will require inotropes. This is traditional teaching. What is transient responders mean? Matlab, you're giving fluids, the CVP is rising, matlab body is responding. But the CVP is again falling, it means there is ongoing hemorrhage or ongoing losses. Like if the patient is vomiting, so he's just continuously vomiting, or urine output is very high, is like that. But when will you end resuscitation? This was the measures to assess whether your resuscitation is fine or not. But when will you end? Actually, when should you end? When the lactic acid turns normal, the potassium at cellular level turns normal. Why? Because you don't want reperfusion injury, and this is the endpoint of your resuscitation. But does serum lactic acid reflects to the tissue lactic acid? Actually, no. The tissue lactic acid could have been different. So we have come up with, okay, first we answer this question and then we'll see. So the best measure for organ perfusion is urine output. Yes. Best to monitor adequacy of shock therapy is urine output. Yes. For clinical indicator for fluid overload. So I told you, यहाँ पर अगर fluid therapy लिखता तो urine output नहीं होता. यहाँ पर shock therapy, it means fluid plus inotropes. It is urine output. Only fluids, it is CVP. All are correct. Understood this? So since we don't have an effective endpoint for resuscitation, I didn't ask you this question. Guys, tell me one thing, whether the question on perfusion was there or not. Endpoints like capnometry, tissue oxygen electrode, was there or not for you? Was there not? So these are the methods which are in trials. Actually, they are not practically possible. We are still trying to find out how can we make it practically possible. These are the indicators that can help us out whether the tissues are responding or not. Like we have parameters for brain, parameters for gut, parameters for heart as well. The only where we don't have a parameter is kidney. So that is one MCQ that can come. For kidney, it is only clinical and it is through urine output. Okay? This is one thing so this is the monitors of organ perfusion. Like I told you, systemic perfusion, lactate and base deficit and mixed venous oxygen saturation, they are one, but they all are investigational. मतलब investigation का मतलब ये नहीं कि अभी trials में, इसका मतलब investigate करना पड़ेगा, मतलब blood sample भेजना पड़ेगा. These below things are possible. If actually I'm from Ames Delhi, so we used to have tissue oxygen electrode there, and we used to have near infrared spectroscopy as well. Gut mucosal pH laser flow droplometry अभी तक इंडिया में नहीं है. सबलिंगुअल कैप्नो कुछ सेंटर्स में है, अमृता कोची वहां पर है. ठीक है. सो दीज आर इन क्लिनिकल यूज, बट एक्चुअली हम इससे इतना प्रैक्टिकल नहीं बना पाए कि हर हॉस्पिटल में अवेलेबल हो. अंडरस्टूड दिस. Let us come back and finish off the blood part. So the first question that came to you was, first successful blood transfusion was done by. Actually, this question history ka hai, it is not very important, and you need to remember only two things. Carl Landsteiner discovered ABO system, and James Blundell did the first successful blood transfusion. That is it. Only two things from to be remembered from this table. Next, let us come to very important points or very important topics. Blood products. First and foremost blood product that we need to discuss is the whole blood. Whole blood actually क्या होता है? Total blood that has been taken out of the body and it has not been disintegrated into various parts. It is the entire blood that is with you, and it is 450 ml. It is leukodepleted to prevent CJD transfer. So Creutzfeldt-Jakob disease is something that has been transferred via WBCs. So you avoid it. But one disease actually, so WBCs को हटा दो तो ये डिजीज रुक जाएगी. अब एक डिजीज और है, मलेरिया. वो कहाँ है? आरबीसीज में. तो आरबीसी को भी हटा दो, मलेरिया भी रुक जाएगा. बट आरबीसी को हटा दोगे तो दोगे तो क्या? दिस इज वन infection that can still be transmitted via blood transfusion, malaria, which we cannot control. Fine. So this is one of the complication of blood transfusion. Leukodepleted for CJD. Platelets, actually, platelets can be functional if given in fresh blood. That is what we think. But problem is, as soon as you take out the blood, the platelet becomes dysfunctional if the blood is not distributed into products within 4 hours. So the minimum time for platelet to become dysfunctional is 4 hours. Because why? To conserve this blood, we are going to use preservatives like sagam, CPD, that will cause platelet destruction. So if you are making whole blood, the platelets will be non-functional. इवन इफ यू लाइक अमर अकबर एंथनी कर लो, मतलब वहां से ब्लड लो, डायरेक्ट ऊपर चढ़ाओ और डायरेक्ट पेशेंट में डाल दो. इफ यू आर डूइंग दिस, only that is the condition जहां पर platelets will be functional. Otherwise, platelets, whenever you put in a preservative into the blood, platelet will become dysfunctional. Coagulation factors, if less than 24 hours में use कर लो, yes, fine, because the half life for factor 7 is 7 hours. So उसकी हाफ लाइफ 7 hours है, मतलब टोटल फैक्टर 7 विल गो विद इन 14 to 20 years. तो विद इन 24 hours अगर यूज कर रहे हो, then it is fine. Coagulation factors can still be used, but more than 24 hours, actually factor 7 कम हो गया, प्रोथ्रोम्बिन ही कम हो गया, तो फिर थ्रोम्बोप्लास्टिन तो मुश्किल हो जाएगा. So this is one thing about whole blood that is important. So 4 factors about whole blood that is important is 450 ml. Leukodepleted will prevent CGD. Platelets are always non-functional. And this was one question. This was given in one question. What is false about whole blood? The only thing false is platelets are functional. No, platelets are never functional. If used within less than 24 hours, coagulation factors are there. Leukodepleted will present Creutzfeldt-Jakob disease and contains 450 ml. Next, let's come to blood products. Important blood products that we need to discuss is PRBCs. What do PRBC contains? We think, sir, it is pure red blood cell, so it should be red blood cells only. No, the hematocrit is only 50 to 70%. It means इसमें थोड़ा plasma है and plus preservatives भी है. So even if you try to remove the entire plasma, there is still a plasma layer that comes along with RBC. So it accounts, if the volume is 330 ml, out of this 330, close to 15 to 20 ml is plasma and 45 ml is the preservative. So that's why the hematocrit reduced to 50 to 70%. This is the 70% wala plasma. If increased to close to 50-70 ml, it will become 50%. What is the temperature they are stored at? 2 to 6 degrees centigrade. What is the shelf life? Now, shelf life depends upon which preservative is used. For example, if you use CPD, it is 2 to 3 weeks. If you use SAG, it is 3 to 4 weeks. If SAGM, 4 to 5 weeks. Understood? So this was very simple thing. PRBCs we all regularly use. Next, come to cryo. Very important. Cryo has fibrinogen, factor 8 and factor 13. So these three things are very important. And when in trauma will come, we'll discuss about thromboelastography. और उसमें ना कुछ ऐसा कुछ होता है. I'll tell you. Alpha, MAR, इन सब को हम उस दिन डिस्कस करेंगे कि इसमें, but for current purposes, remember fibrinogen, factor 8, very important. Actually, cryo was made for factor 8. इसीलिए से anti-hemophilic, they are stored at -30 and the shelf life is 2 years. Next is fresh frozen plasma. मतलब almost all factors होते हैं except factor 5 and 8, जिनकी half life 7 घंटे से भी कम होती है. कोगुलोपैथी में यूज होगा of unknown origin. हमें नहीं पता किस वजह से हो रही है, सब कुछ दे दो. नेक्स्ट इज प्रोथ्रोम्बिन कॉन्सेंट्रेट. इसमें क्या होता है? व्हाट इज देयर इन दिस इज फैक्टर्स which reverse warfarin toxicity. So what are the factors warfarin act on?
2790.
2790. Sarvajit, do you have any issues remembering it?
No.
If you don't have, I'll tell you a mnemonic. So what do you, shall I tell you a mnemonic or it is okay?
You can tell, sir.
Okay. So tell me, to remember this mnemonic, you need to tell me one more thing. What cranial nerves are mixed? Can you name cranial nerves which are mixed nerves? So I'll tell you. Like मुझे मिक्स सब्जी 5 7 9 10 मतलब प स न द पसंद है इसका ही जब पसंद है तो मैं दूंगा तो मैं दसंद दूंगा 2 7 9 10 ठीक है
Okay, sir.
this is how I remember it is bit in Hindi so you can remember it in one single line what factors are there in PCC 2 7 9 10 that is dasand that is the only thing that is to be remembered about PCC. I tell you one simple fact FFP, unknown coagulopathy. Cryo, hemophilia. PCC, warfarin. As simple as that. So you will automatically remember what is there in that. Okay? The only thing you need to remember is 5-8 is deficient in FFP. And I think this must be the question. Okay. What is false? PRBC does not have only RBCs. The hematocrit is 50 to 70. That is true. FFP minus 40, cryo minus 30. Yes, that is also true. FFP lack factor 5-8. Cryo has factor 8 and one is fibrinogen. That is true. PCC are used for heparin. No, warfarin. What is used for heparin toxicity?
Vitamin sulfate.
Protamine sulfate. Very good. Next question is autologous blood transfusion. When can you give it? So it is actually if you donated blood for your own use, you can do it up to 3 weeks. Why up to 3 weeks? Because after that, the blood affinity, though it is being preserved for 5 to 6 weeks also using sagam, but the affinity or use of that blood becomes very less. So viability of the RBCs is low. If you guys remember the hemoglobin curve, left shift, right shift, left shifted hemoglobin curve does not return to the normal after that particular patient. And when you are giving it for a patient whom you want 100% of RBCs to be used, ऐसा नहीं कि बिल्कुल खत्म हो जाता है 5 weeks पे the efficacy because the patients needs to develop the immunity as well as RBC on their own. If you remember, these patients after transfusion will be started on iron and iron will take almost 2 weeks to build up hemoglobin. So 1 week extra we give as a reserve. So up to 3 weeks, we usually retransfuse them. Next, complications. The most important thing you need to remember is malaria. That is there, which we can forget. Rest you will remember. Hepatitis, HIV, you remember. Febrile transfusion reactions that happens, you remember. Surgeon point of view say it is not very important. What is important is massive transfusion. What is not there in massive transfusion? हाइपो दोनों कलीमिया हो सकता है हिपोकैल्सीमिया ही होगा क्योंकि कोगुलेशन फैक्टर दे रहे हो कैल्शियम तो यूज हो ही रहा है बॉडी का सो कैल्शियम इज बीइंग यूटिलाइज्ड you we are only transfusing the patient with coagulation factors it can lead to hypocalcemia as that's why with massive blood transfusion you always order calcium as well as lasex so as not to cause fluid overload. I think with this the entire shock and hemorrhage part from Bailey is done. If you have any questions, let me know.
No, sir, it was a great session. Thank you.
Thank you. Thank you, Darshit. Keep learning, keep growing. With this, we end this session.
Yeah, yes, sir.
Okay, great. Sure. Thank you. Good night, man.